طيب طيب يعطيكم العافية. We will finish prostate cancer today إن شاء الله. We stopped with the hormone or castrate refractory disease. We said that at some point, maybe after we try several different hormonal treatments, and androgen-dependent disease becomes refractory, which means no longer responding to androgen blockade or hormonal deprivation. And so we call this hormone refractory disease. And then we have to switch to another treatment, like in first line, we use chemotherapy. And we said that usually docetaxel prednisone is the very first line in most cases, okay? We have other drugs that can be used as well, but docetaxel prednisone is usually the first line. In case docetaxel was not effective, okay, then we can shift to a second line taxane-based regimen that contains cabazitaxel. حكينا إنه cabazitaxel is more resistant to resistance. يعني it's not subject to the efflux pump effect in which docetaxel can be removed by tumor cells. فهو يعني إحنا بنعتبره second to docetaxel to patients who fail therapy. We can also use radiation therapy and palliative therapy. هلا في عنا other drugs like enzalutamide, like abiraterone, كمان هدول can be considered in patients with metastatic castrate-resistant prostate cancer. Other treatments we can use, although at a little bit low scale, we can use immunotherapy. If you recall اللي حكيناه لما حكينا عن ال CLL and we talked about CAR T treatment, we have another immunotherapy اللي هو Sipuleucel T. Basically what we do here, we try to isolate antigen presenting cells from patients. We take a blood sample, we do leukapheresis in the lab, we isolate the antigen presenting cells. اللي أخذوا immunology, you know that antigen presenting cells are usually the very first type of immune cells that present antigens to the other cells like T cells to start an immune attack. فبالتالي we try to modify or manage antigen presenting cells by exposing them to a particular antigen. طبعا هاي الانتيجنز يجب تكون isolated from the patient tumor itself. يعني this is a very personalized medicine. So we take the immune cells, the antigen presenting cells from the patient. We try to understand the tumor biology and isolate particular potentially immunogenic peptides, mostly antigens from the patient tumor, and then we co-incubate and try to generate antigen presenting cells that can already present the antigen and are fully activated. We grow these in lab, and then we re-infuse them, we re-inject them to the same patient. And then we expect that these activated antigen-presenting cells will be able to activate cytotoxic T lymphocytes against the prostate cancer of that patient. And so it's like indirectly boosting, enhancing cytotoxic or T cell mediated immunity to recognize the antigens and to attack the prostate cancer in that particular person. فعشان هيك احنا بنقولها autologous immunotherapy. Autologous, why? Because the immune cells, the antigens usually come from the same patient, and this is very, very personalized. And this is a process, high procedure. يعني ما في one gene that can work to all patients. أو يعني there is no standardized cells in the lab. لا احنا بناخد الcells من patient. We try to isolate very antigenic molecules from the tumor and then process the therapy and re-inject to the same patient. But what might work in one patient might not work for the other. فهي process, and this is a very personalized medicine. هلا to be honest, الimmunotherapy اللي لقيوها أنا مش كتير it will help the very aggressive disease. يعني إحنا ممكن نعطيها بالmetastatic patients especially إذا كان عندهم يعني minimal أو mild disease يعني ما كانوا very symptomatic. We can consider immunotherapy before chemotherapy. Okay, in هاي الحالة you might think of immunotherapy. However, generally symptomatic patients we consider usually in first line we consider chemotherapy. In some cases we might consider abiraterone before docetaxel. يعني الابيراتيرون احنا حكينا عنه as anti-androgen and a prodrug. You might try it before docetaxel in certain cases for castrate-resistant metastatic prostate cancer. But if you go directly in this case with docetaxel, it's also correct. Okay. لكن the other options اللي هم الانزالوتاميد والكابازيتاكسل should not precede docetaxel. يعني under any case you should not in a patient ما أخذ docetaxel أروح أعطيه أجرب له مباشرة كابازيتاكسل. It's not approved in this case. مش قبل docetaxel. Same thing with enzalutamide. Enzalutamide can be considered after docetaxel. فبالتالي after docetaxel we have many options. We have cabazitaxel, enzalutamide, abiraterone also can be given. فإذا الabiraterone can be considered before docetaxel or after docetaxel. Actually اللي احنا بنعمله I don't think this immunotherapy موجودة بالأردن. I'm not sure يعني I'm not aware. It may be there but I'm not aware. لكن what we do actually is usually we go with docetaxel and see patients responding, that's fine. If not, then we can consider cabazitaxel and enzalutamide. مش أكيدة كمان إذا الأبيراتيرون موجود أو لا. Okay, it might be there. أحيانا الأدوية ما بتكون موجودة. Patients will buy on their own وبيجيبوها بس ما بعرف إذا موجودة بالفورميلاري أو nationwide يعني. But docetaxel prednisone is very important first line therapy بالمرضى اللي عندهم castrate resistant prostate cancer أو hormone refractory. هلا newly introduced okay هو nuclear medicine using radioactive isotopes with radium 223. هلا هذا كمان بينعطى للمرضى اللي هم castrate resistant metastatic prostate cancer especially إذا كان في bone metastasis. يعني إذا كان already هذا المريض عنده bone metastasis and symptomatic we can try radium 223. Okay, فهذا كمان is a little bit something new بالmanagement of a prostate cancer. طيب هلا guidelines, this is really important. How we treat and how we choose our therapy. هلا المانجمنت بتعتمد على two factors اللي هم recurrence risk. What's the potential for the tumor to have recurrence? Okay. فالrecurrence risk ممكن يكون very low, intermediate, high and very high. Okay. فبالتالي احنا هون لما بنحكي low, very low احنا هون ما عم نحكي عن grade of tumor احنا عم نحكي عن recurrence risk وعندنا كمان expected survival in years. Okay. فيعني what is the expectations في عندنا life expectancy هون. Okay. هل do we يعني expect prolonged يعني expectancy 20 years of to come مثلا أو 10 years to come and so on. هذا بيدخل as a factor in life expectancy and based on these we use initial therapy. هلا to decide about recurrence risk we look at the tumor size, Gleason score and PSA level. بمعنى how to define patients with low risk. يعني كيف أنا بقدر أعرف to assess my patient إنه هذا البيشنت عنده low recurrence risk. بده يكون عنده هدول الثلاثة okay together existing together. فانتبهوا إنه أحياناً المودريتر بيكون and وأحياناً المودريتر بيكون or. okay فانتبهوا إحنا لما بنقول or يعني we have 3 points عندي tumor size, Gleason score, PSA level. فإذا أنا بقول this or this or this إذا any one implies intermediate risk. يعني مثلا إذا أنا باجي بطلع على intermediate risk of recurrence T2, B or C or Gleason score 7 or PSA 10 to 20. فبالتالي البيشنت بيجي عنده one of these three، مو ضروري مجتمعين الثلاثة، any one implies intermediate risk. Okay. بينما لحتى يكون at low risk we have to have these three existing together. يعني لازم يكون very small tumors T1 or 2A. The Gleason score هو below range below 7 اللي هو يعني 2 to 6 بيجي ب ال well to moderate differentiation. اوكي يعني لما بنحكي Gleason score من 2 to 6 احنا بنحكي عن highly differentiated and moderate differentiation بمعنى we still not in the very aggressive disease or the high grade. فبالتالي small tumor size يعني well differentiated tumors moderately high PSA بمعنى PSA level is not very high. It is elevated يعني هون هو elevated but it is not very high. When these three exist together احنا بنعتبر انه البيشنت عنده low risk of recurrence. Then we come to assessment of expected survival, life expectancy. Okay. هلا اللايف expectancy بالفيري لو عادة يعني الفيري لو حتى يعني مش معرفينه منكم بالكتاب بس حتى يعني they have better prognosis than these three together. Okay. الفيري low patients هون we look at life expectancy at 20 years old. يعني can the patient live for another 20 years or not? Okay, more than, less than. هلا إذا عندنا expectation life expectancy in the very low group هي less than 20 years, observation is usually what we have to do. We keep the patient under expectant watching أو management. إذا أكثر من 20 years, we expect the patient who has very low risk of recurrence to live maybe 30 years, 40 years. هون ممكن we offer other options beside observation like prostatectomy or radiation. فإذا إحنا بنحكي prostatectomy, it definitely implies إنه إحنا عم نتعامل مع a very يعني very local disease. Okay, you can offer prostatectomy, you can offer radiation. With mild disease, you can offer brachytherapy. With more aggressive disease, you can offer external beam radiation. Okay, فبالتالي observation can be considered for both the groups. بس إحنا حكينا كل ما life expectancy بتصير أطول أو التيومر بيصير aggressive أكثر بغض النظر عن life expectancy إحنا we can offer other source of therapy. Okay, فهون you can offer prostatectomy, radiation. في شغلة كمان لاحظوا إنه life expectancy هي consideration when we treat very low intermediate risk patients. However, when we go to the high and very high risk groups, life expectancy is not anymore a factor. يعني لما أنا بصير عندي patient already عنده high risk of recurrence, usually aggressive, maybe locally advanced tumors, okay, like in T3A, هون ما بيفرق معي إنه the patient has long or short life expectancy because here the tumor is very aggressive and must be treated. فبالتالي بهاي two groups of recurrence risk, we don't consider life expectancy as a factor. فإجا المريض عنده life expectancy 5 years مثلا أو 20 years, we treat in almost similar way. Okay. فlife expectancy هي consideration بالمرضى اللي هم very low to intermediate risk of recurrence. فإذا إحنا عندنا low risk patient recurrence عم نحكي السؤال إنه life expectancy less than 10 or more than 10. Less than 10, wait, why? Expectant management, these tumors are in general we consider them indolent. Okay. طيب إذا إحنا عندنا life expectancy يعني we expect it to be more than 10 years, we can offer يعني beside like expectant management we can offer other options like prostatectomy, radiation. فهو إحنا نقول or this or this or that. Okay. فبالتالي بيشبه هذا السيناريو أكثر بيشبه ال very low. risk of recurrence. Okay. هلا بالintermediate recurrence risk, as you can see, tumor size is started to increase. Gleason score started to increase. لما احنا بنحكي Gleason 7 عم نحكي عن a little bit more aggressive tumor. كمان PSA started to increase. يعني عندنا هون a little bit more aggressive disease. فبالتالي يعني يفضل بهاي الفيز انه احنا نعمل management. إلا إذا كانت life expectancy very short we can still wait. لكن most the cases هون إحنا we consider treatment. فإذا كان عندي life expectancy more than 10 years or more, we can do prostatectomy, okay? We can do radiation, and we can give short course of androgen deprivation therapy. فلما أنا بقول short course of androgen deprivation therapy, like إحنا حكينا, first line is an LHRH agonist. If not available, you can use gonadotropin releasing hormone antagonist, okay? إذا مش doable pharmacologically ممكن نعمل مثلا archectomy أو يعني some other invasive castration method and so on. لكن هون إحنا بنعطي pharmacological therapy for 4 to 6 months. فإحنا بنعتبرها short duration. So you can consider any of these, okay? You can consider local treatment with radiation, prostatectomy, or you can consider systematic treatment with androgen deprivation therapy. هلا in less than 10 years, we have the same options here. When we talk about expectancy less than 10 years, we have same options here plus observation, okay? Observation is not an option for patients with prolonged life expectancy when they have intermediate risk of recurrence. ممكن يكون يعني ممكن يكون option بالمرضى اللي عندهم shorter life expectancy. To be honest يعني إحنا we try to do something لأنه هاي التيومرز هون إحنا ما عاد نعتبرها indolent. إحنا Gleason score 7 is aggressive carcinoma and high grade. So we can offer prostatectomy, we can offer short course of androgen deprivation therapy, we can offer brachytherapy, we can offer radiation, and we have many things to offer the patient, okay? لما نروح على high risk, as I said, بالhigh risk إحنا ما عنا يعني life expectancy is not a factor. بالhigh risk we have larger tumors, فإحنا ندخل ب 3A tumor size. Gleason score is even higher. طبعا 8 to 10, in 10 هو very high, okay? With PSA even higher than 20. We have really an aggressive disease. فهدول المرضى إذا بدنا نعطيهم إحنا systematic treatment, we usually give androgen deprivation therapy for 2 to 3 years, okay? فهون المريض بده ياخدها على long term أكثر because the risk of recurrence is higher, okay? عادة بنعطي معها radiation with or without brachytherapy. We might consider also prostatectomy in patients who are maybe eligible, okay? فهون بالhigh risk of recurrence الcornerstone صراحة هو ADT. Okay, we have to give androgen deprivation therapy. With it, we can give radiation, we can do prostatectomy, or we can do brachytherapy, okay? فهون ADT for prolonged time, 2 to 3 years, okay? يعني we start as monotherapy, okay, هون يعني بنعطي monotherapy with LHRH agonists, and we monitor the patient with LHRH agonist. ممكن نعطي أو نعمل radiation أو ممكن نعمل prostatectomy إذا المريض يعني eligible, okay? هلا عندنا very high risk. في عندنا metastatic phase, okay? احنا حكينا المرضى ال D1 وال D2 disease هم metastatic prostate cancer. Involvement of regional lymph nodes, like if you see here N1, okay, بغض النظر عن tumor size, بما إنه وصل لتيومر على pelvic lymph nodes, then this is metastatic disease in prostate cancer. فإحنا بنعتبره metastatic disease. أو إذا وصل على pelvic bone or distant sites, كل هدول إحنا بنعتبرهم metastatic disease. Okay? هلا ال very aggressive and very huge tumors إحنا بنعتبرهم very high risk of recurrence. فهون T3B and 4 هو مش metastatic. It's not metastatic here, but very high risk of recurrence because the tumor يعني هذا بنعتبره very locally advanced. Okay. وال N1 disease أو ال M1 disease هون هدول إحنا بنعتبرهم metastatic أو هدول stage D disease. Okay. هلا ال very high risk but still not metastatic disease same idea more or less. إحنا رح نعطي long term 2 to 3 years of androgen deprivation with or without radiotherapy or prostatectomy. هلا بصراحة البروستاتكتومي طبعا we can still consider it here لأنه this is not metastatic يعني برغم إنه locally advanced it did not metastasize. However it's يعني its impact or value is not big. يعني البروستاتكتومي لما بصير عندي very locally advanced disease يعني you can still consider it but it's not very يعني outcomes ما بتكون very big actually complications of surgery might be huge. We can still offer it, okay. لكن هون we can still go with ADT alone or with brachytherapy, or we can do prostatectomy and start the patient on ADT as well. بالvery high أو metastatic disease, we have many options. Okay, prostatectomy is not an option here. يعني هون بالmetastatic disease, you will not see prostatectomy. It's no longer an option. فبالvery high risk, what we can do, we can give androgen deprivation therapy 2 to 3 years as monotherapy. مثل ما حكيت ال LHRH agonist as monotherapy we can give them, or from the very beginning ممكن نعمل combined androgen blockade. يعني هون احنا عم نعطي ال anti-androgens like flutamide with the LHRH agonist for 2 to 3 years. احنا هون ما عم نعطي just for few weeks to control the flare. لا احنا هون من البداية we are intending إنه نعمل combined androgen blockade لأنه هذا metastatic disease, aggressive disease. ممكن كمان نعطي ال LHRH agonists alone, okay, لأنه أكيد لما نعطي هدول الاثنين it's going to be a little bit more toxic therapy and more costly. So we can start LHRH agonists as monotherapy, androgen deprivation therapy هم تنعطى 2 to 3 years. ممكن نعطي ال LHRH agonist أو ال androgen deprivations مع ال anti-androgens for 2 to 3 years. ممكن نعمل مع ال androgen deprivation therapy archectomy أو radiation. Okay. فإحنا هون يعني we can consider archectomy. سألتكم إنه شو ال options to consider archectomy. We have 2 settings. Okay. منهم يعني إضافة عليهم في عنا ال metastatic very high risk patients. We can consider radiation. عادة radiation هون بتكون external beam ما بتكون brachytherapy لأنه the disease is very aggressive. If we give systemic androgen deprivation therapy, we do it long term 2 to 3 years. فبالmetastatic disease we have many options. If you start any of these, that's okay. You can go with any of these. لكن بالmetastatic stage D, prostatectomy is not usually an option, and brachytherapy is not usually an option. Okay. سؤال على ال guidelines. It is not difficult, but you have to know it carefully. Okay. كل يعني كل phase أو disease stage أو خلينا نقول recurrence risk, how to treat, what are the available options to treat. Okay. طيب هلا as I said here, okay, ال D1 D2 disease اللي هو metastatic phase, we can use LHRH agonists. We can use with them. We can use archectomy. We can use anti-androgens. حكينا إنه في عنا hormonal therapies بالsecond line like estrogens and progestins, aminoglutamide, ketoconazole. You can use these, but usually estrogens and progestins يعني هدول الاثنين they have a very high risk of cardiovascular disease. Progestins ممكن يعملوا لي hypercoagulability. فهم يعني side effect لهم sometimes the benefit risk ratio might not be very much balanced towards the benefit. فبالتالي we can can still consider them but they are rarely indicated بهدول المرضى لأنه they are very toxic especially المريض already be very advanced stage of the disease. هلا very high risk but not metastatic disease as I said usually they are not candidates to prostatectomy or brachytherapy. عادة احنا بنعطي systemic LHRH agonist 2 to 3 years. ممكن نعمل معاها radiation أو يعني إذا يعني ما تجاوب المريض ممكن then later on we introduce anti-androgens as a combined approach. Okay. The prostatectomy could be considered بس هي ما بنعتبرها good option لأنه هذا بنعتبره locally advanced disease. Okay. طيب هلا evaluation of outcomes المرضى اللي احنا يعني we think they are candidates to the expectant management must be يعني thoroughly and carefully and frequently monitored. هذا المريض إذا بصير معه progression in any case يعني بعمل له PSA بلاقي إنه صار مثلا serious elevations أو digital rectal exams shows abnormalities أو tumor size increased anything يعني urinary symptoms deteriorated any sign of progression we have to start treatment accordingly. Okay. Patients who finish the systemic therapy نفترض إنه مريض كان low risk or intermediate risk وأنا أعطيته مثلا short course of androgen deprivation therapy. The patient was stable, did well, صار عندي tumor shrinkage, PSA declined, digital rectal exam improved. You can stop therapy, but patient must be يعني checked frequently بالبداية then you might decrease the frequency but they have to be checked على ال BSA وال DRA. okay. فإحنا يعني ممكن نعملها more frequently in the beginning لكن على الأقل قراءة أو قراءتين 1 or 2 readings of PSA annually will be very important during the disease-free phase. Okay. Metastatic disease, especially bone metastasis, we can irradiate the bone, okay, to reduce pain and يعني شوي improve the quality of life عند المريض. طبعا ممكن نعطي يعني some therapies directed to patients who have bone metastasis like cylindronic acid مثلا, vitamin D and calcium can be considered. هدول المرضى must be followed for potential cardiovascular complications with the androgen blockade treatments or deprivation therapy, potential for metabolic side effects like metabolic syndrome or diabetes مثلا لأنه أو hypercholesterolemia. Okay, all these can be يعني potential complications. مثل ما حكينا إنه يعني expected with these interventions إنه ممكن يصير يعني impairment in sexual activity and decreased libido and so on. We also try to يعني إنه المريض counseling and stuff like that لحتى شوي نحسن the quality of life, especially لما بتكون بالadvanced stages. With PSA and DRE, these must be done to all patients اللي عندهم diagnosis of prostate cancer بغض النظر at what frequency. Okay. By this we are done with prostate cancer. أظن إنه بالprostate cancer I think إنه we ask you for the treatment part only بس أنا رح أنزل لكم details إن شاء الله maybe in a couple days أو over the weekend إنه شو المطلوب من prostate cancer. We'll stop right here. ما رح نكمل solid organ transplant as I said before. فهيك بتكون إن شاء الله مادة الفاينل فيها 5 chapters for final زائد مادة الميدترم. Okay. Before we finish في طالبة اسمها خالدة المناصير. Please talk to me.